Hello and welcome to Module 8 of the LNET course. We're going to be talking about the final hours. So in this video series, we're going to talk about immediately prior to death, how to look at, assess, identify, and address physical signs and symptoms and the dying process. We're going to talk about the different needs in a holistic and comprehensive manner of the dying patient and family. And we're also going to discuss the role of the palliative nurse in caring for the patient at the end of life and at death. NCP guidelines, of course, remember this all draws back to that. We're going to talk about Domain 7, caring about the patient nearing the end of life. I'll let you pause the video and read the information on the screen. A good death generally does not occur without thoughtful planning and anticipation. Nurses have this sacred role of being present at the time of death and those moments leading to death and that incredibly intimate time for the patient and the family members. There are multiple things to think about, things like hydration, resuscitation, hastening death, and what does a good death mean? So I encourage you to pause for a second here and consider, what is a good death? What does it mean? How does it differ from person to person? What goes into a good death? And how can we ensure that each patient we care for has a good death? Everybody dies, and that is why it's necessary to prepare to guide the person into death and ensure that they do have that good death. Remember that about 60% of Americans live with at least one chronic illness, and of those, 40% have 2 or more chronic illnesses. 7 out of 10 causes of death are from chronic illness. So people really are dying for years or have been sick for years with multiple comorbidities and have suffered with their families. They're exhausted. And in some cases, the patients and their families may be financially broken. Advanced care planning is very important to lay out a blueprint of the patient's preferences regarding the end of life. Advanced care plans really work to increase the likelihood that the patient receives care consistent to their wishes. It is helpful in decreasing healthcare costs, it improves quality of life, and it really improves bereavement outcomes. The ANA offers several position statements that support the nurse that's caring for the patient at the end of life and initiating these discussions and decisions. And for those living with serious life-threatening or chronic illness, recognizing different approaches to death allows the patient and their family, as well as the care team, to actively prepare for the dying process. So when a patient's death is imminent, the nurse really needs to be cognizant and committed to providing expert symptom management, to know and respect the patient's culture, to help prepare the family for what to expect as death approaches, and to anticipate and notify other members of the healthcare team, the interdisciplinary team, what may be needed. Planning for and providing care after death includes death pronouncement, care of the body, discussing burial plans, and bereavement care. Nurses tend to have more exposure to death than any other healthcare profession. The final days before a patient dies are really the most significant moments for the patient and their family. And as they prepare for death and say goodbye, they work to complete the end-of-life closure tasks. The nurse really works as an advocate and a companion and in the role of caregiver, supporter, educator, and is often the one to facilitate a dignified and comfortable death that really honors the patient and family choices, no matter the setting that death occurs, because remember, death can occur in any type of care setting or home or community setting. The nurse really needs to be comfortable being with and bearing witness with to the dying of the patient with the family members. And caring of the dying, again, I cannot stress this enough, it really needs to happen in an interdisciplinary way. So the nurses closely collaborate with physicians, chaplains, social workers, and all other members of the care team. It's important for the nurse to be able to be flexible and to recognize when the typical rhythm of care needs to change. So things like taking vital signs, input, output, daily weights, just the typical routine of nursing care. When does that need to change? What is appropriate and what is not appropriate for the patient? If you have observed a death, whether it's family, whether it was in a clinical setting, what have you, reflect on that and think what went well. Were the wishes honored? Were there cultural traditions that were honored? Was pain and other symptoms, were those controlled? What could have been improved? What issues were there that could have been prevented? And then if it was within any setting that it was in, are there policies or procedures that needed to be developed to be able to provide better care? As you do witness death in the future as the nurse, think about this. What went well and what could be improved? Develop that habit of reflective thinking in everything you do. Okay, what went well? What can be improved? Remember that honest, open communication fosters trust, and it really helps with informed decision making. So in all communication, be sure that you're conveying empathy and caring, sensitivity, compassion. It's important to listen to patients and families' understanding of the condition and prognosis. So patients may have greater awareness of dying than those around them. So if the patient asks if they're dying, explore that question. What makes you ask that now? Has something changed? Encourage open and honest communication between patients and families. And if the family is reluctant to address death with the patient, address these concerns. Educate the family on what the patient may already know about their dying. Prepare for death. Being prepared for death, it really leads to better bereavement outcomes. Be sure to provide simple, uncomplicated information. So use layman's terms, avoid jargon, avoid overloading and overwhelming with too much information. Provide simple answers to questions, and be sure to assess the understanding of the patient and families of what they heard you say. Have them repeat it back to you. Explore what they understand from you. Be prepared to answer the same questions over and over and over and over. Often, individuals in crisis or in an emotional time, they're not able to retain information. The brain just doesn't retain information. And so, continued repetition with patience and compassion is really, really important to families at this time. There is no such thing as a typical death. So every person dies in their own way, in their own time, with their own culture, belief systems, with their own unique relationships to their friends and family. When patients are aware that they're dying, they usually know where they want to die, who they want to be there, and how they want to die. So the nurse really can advocate for that patient in exploring how it is they want to die. Again, that good death. What does that mean to the patient? And then the nurse can collaborate with the interdisciplinary team to help provide that optimal end-of-life care within the practice setting, whatever that happens to be. Open and honest communication, again, with the patient, with the family, with the care team, that is all necessary to support the patient and family in end-of-life care. So the patients and families, they will have psychological and emotional concerns. There may be fear of the dying process, fear of abandonment, fear of the unknown, nearing the witnessing of death, death awareness. They may become very withdrawn. So everyone is going to respond in their own way. Now let's talk about some of the questions that arise when end of life comes about. Remember, we show people that we love them through food by providing nutrition, hydration, and there's this perception of families that we may be starving people to death. And that is It's important to provide that education again to the family with words that they understand, that the body is shutting down, that the GI tract is slowing and shutting down, and so it doesn't need the nutrition for one, and it's unable to process food. And so rather than food being a comforting thing for patients, it's now going to be something that they are going to regurgitate or vomit, potentially aspirate. And it's not starving to death, it's not starving the patient to death. It is changing the care to address their needs, and their needs are to have decreased intake of food at that time. The question of hydration is another one. We again want to nurture our patients, nurture our loved one. And dry mouth is one of those common symptoms at the end of life, if you remember from our symptom series. Hydration, IV hydration, does not address dry mouth. So there are going to be other ways to address this. Those little swabs are going to be a great way to soften. Providing oral care is another great way. Applying chapstick to the lips. There are ways other than IV hydration to address dry mouth. An important thing to remember and to provide education to family members is that hydration, parenteral hydration, tends to prolong life, and it's not going to promote comfort in the patient. So when families are asking, are we doing everything, it really comforts them when you provide this education and say, we are doing everything we can to make them comfortable, and that does not include providing nutrition and hydration. Culture influences the death experience. It affects how people view death, their distress, or their peace with it. It affects different social customs, such as care of the body or different bereavement rituals. It affects how people talk about death, and really it can enhance or place strain on relationships between caregivers and patients and their families. It also affects decision making. And it's important for the nurse to remember 3 ethical principles during this time. So, autonomy, family or surrogate and patients' rights of self determination. They have the right to determine whether to accept or reject these interventions based on their own beliefs and values. So, remember autonomy, beneficence, to do good, to act in the interest of the patient, and then non-maleficence, to do no harm. Really speaks to respecting the wishes of the patient, family, or surrogate decision maker to bring no further suffering. And this is really considering that benefit burden ratio. The public frequently has unrealistic beliefs about survival after resuscitation. And this is largely due to the media based on favorable survival portrayed in Hollywood and movies. You know, you give someone CPR, they bounce back to life, they're exactly as they used to be. Well, this is not the case. Outcomes after resuscitation, especially within the hospital setting, are very, very poor. Approximately 40% of patients who have CPR after cardiac arrest survive immediately after receiving CPR. So that's positive, but only 24% survive long enough to be discharged from the hospital. So while it may initially save a life, the long-term outcomes are poor. It's also a very violent process. For anyone who's been involved in CPR, you know that the ribs break, that the sternum cracks. It's very hard on the body. So if you have, especially an older, frail person, recovering from that is incredibly difficult and painful, even if they are able to be resuscitated. So it's important to educate the family on this. Let them know the reality of resuscitation. You don't have to scare them to death or be graphic, but just let them know that it's not like you see in the movies, and typically recovery after CPR is a long, painful process, assuming that it works at all. So ask them, what would your loved one prefer? Do they want to spend their last moments in a room full of strangers on a ventilator in pain? Or do they want to spend their last few moments surrounded by friends and family and those that they love? Now, in the case of sudden death, typically there's not going to be advanced care planning that occurs, and CPR must be initiated if there is not a DNR order. So sudden death, it's a much different story. Traumatic accidents, a much different story. But in the case of chronic illness, it's important to have these difficult yet critical conversations with the patients and their family. Over 500,000 Americans are on dialysis today. And these are all older adults, typically 60 years of age or older, and have multiple comorbidities. These comorbidities come with a very high symptom burden. Anyone over the age of 80, which is the fastest growing segment of the dialysis population, 46% of those individuals, the mortality rate is within the first year of dialysis. So that raises a question: when should dialysis be discontinued? The burden of dialysis often outweighs the benefit. And when dialysis is no longer prolonging life, but only prolonging death, that's the time when that ratio, that burden-benefit ratio, is no longer in balance. The most common reason for discontinuing dialysis is poor quality of life. Things such as pain, burden of multiple symptoms, acute complications such as infection, or difficult technical problems with dialysis, dementia, stroke, cancer. These types of things are the most common reason for poor quality of life within dialysis. So in assessing those burdens, along with the psychosocial symptoms, it's vital to consider the decision-making process of when to consider dialysis discontinuation. So bring up that conversation with the family. Because patients on dialysis, they often struggle with depression, changes in body image, sexual dysfunction. They have a loss of control, increased irritability, a lot of dependency issues, in addition to the numerous physical symptoms. So again, when we have a patient on dialysis, continuously be thinking about that burden-benefit ratio. Organ donation is an important thing for families to consider. Approximately 85% of organ transplants come from deceased donors. If the patient is an organ donor, it's important to follow the procedures in accordance with the care setting and the guidelines, policies, all of that. That will all be outlined in your own facility, and that will be guided by whatever organ procurement organization governs or is active in that area. So for this area, it's Life Center Northwest. They are the organ procurement organization for Washington, Oregon, Idaho, I believe Alaska, parts of Northern California, and so this is basically the Pacific Northwest area. If the patient is not an organ donor, that can be brought up to the patient and the family. However, the procurement team or the organ procurement organization will bring up that discussion with the family. So healthcare professionals are not permitted to discuss this. The procurement team is going to talk about it. They have, they're great about it. They're very respectful, very compassionate, and that's one thing that you won't discuss. You can ask if they would like to talk to the team, but you're not going to discuss it with the family. Often organ donation brings a lot of comfort to families. It can be a way for their loved one to live on and make a meaningful difference. I've been a part of multiple organ procurement procedures, and it's very respectful to the patient, to the family, and again, Life Center Northwest is absolutely phenomenal in caring for families as well. It's not uncommon for patients to ask healthcare professionals to help them hasten their death. I have cared for a patient who was actively, with ALS, that was actively seeking the medically assisted suicide, and then another patient I had mentioned in a different video who was asking me about it. The request may come from persistent symptoms that are really prolonging suffering. It could be a loss of control, anxiety, fear of being a physical or financial burden to loved ones, and this request can cause healthcare providers a lot of angst. But it's an important opportunity for the patients, and it's important to be aware of the patient's suffering and look at ways to provide better assessment and care. So if a patient brings this up, and likely it will come up, explore the motivations. Why are they asking this? Is it physical symptoms that they're experiencing? Do they not want to be a burden to others? Explore alternatives to address the issues that are being raised. Assure a non-judgmental commitment to care. Openly discuss the patient's request with the patient and with the care team. Don't make it a big secret or some sort of scandal, and absolutely seek interdisciplinary support as you care for the patient. Because we only die once, nobody really has experience with this event. So it's not unusual for people to be very afraid or to worry about what is to come, or being abandoned, or being anxious of not having control over pain or suffering, both physical and existential. So patients experience great losses, including body parts, dignity, control, self-esteem, and towards the end of life, patients may choose to be more introspective, focus on maintaining a sense of self. They may be seeking meaning in their life and pursuing different ways of leaving a legacy. So it's not uncommon for patients to become very withdrawn or quiet, or to sleep a lot more. This is very typical to see near the end of life. Many patients and families have an increased focus on spirituality or religiosity as death becomes imminent. So having that spiritual assessment, religious assessment, cultural assessment is important. You don't have to be an expert in any of these things. All you have to do is bring up the question. Do you have any spiritual concerns? Do you have any cultural rituals or ceremonies or rites? Do you want prayer? Bring your chaplain in. Ask if the patient or family would have a priest or rabbi or an imam or whatever spiritual or religious leader that is important to them. See if you can contact them and bring them in as death draws near. So that wraps up our first video on the final hours. And write down any questions and really just ponder to yourself, what is a good death? What does that mean?